All right. Hey, everybody. Welcome to season 2, episode 2 of Coffee Compliance and Chuckleheads. We had just an interesting technical glitch. There was a giant bang, and then all of a sudden, everything went dark. Nothing, Eric?
I mean, this is what happens when you're in the South.
I was waiting for that. There it is.
The thunder bumpers. Isn't that what they call them?
Thunder bumpers.
Yeah.
Yeah, that was, man. And then, of course, I'm sitting here and I'm like, I can't say any bad words because I'm in my studio and my granddaughters were just outside of the studio. And, they tell on me for everything that I do. I mean, there is nothing that I can do that I can actually get away with.
Yeah. Jordan got scared. In fact, he got so scared his mustache fell off.
Oh,
he had it. It was on when we were in the preview. He had it, and then the thunder boomer came, and he got scared. His mustache fell off, and then he was actually apparently able to do some watercoloring while he was waiting in the back there. So
paint by numbers.
Yeah.
So
well, I'm glad you're back.
Yeah, I am too, man. That was a little spooky, but
yeah.
Hey,
while you were gone, the national debt rose by $1 trillion as a result of the extension of the public health emergency.
Yeah, we're going to get to that in just a moment. But, I'll tell you something that I want to talk about real quick, if it's okay. I want to talk about Elon Musk buying almost 10% of Twitter. I got to tell you,
Jordan, you're on mute, so what you're saying is probably pretty important, but we just can't hear it.
But here's what I want to say. It's unbelievable because Jordan must have gotten to thunder.
He finally got offended enough at me that he decided he was done being on this show.
He heard enough of the mustache jokes.
He's still
muted. That may be best for all of us, but that
may be better. That's all right.
So
yeah.
So here's the deal, right? Elon Musk bought 10%, just under 10% of Twitter, and they wanted to appoint him to the board. Now, if you wonder why they wanted to appoint Elon Musk to the board, it was to keep him from criticizing the company even more than what he's already been doing.
Of course.
But by becoming a board member, he'd be limited in his stock purchase to no more than 15% of the company. Well, Elon decided, no way, guys, not playing ball, turned it down. Apparently, it sent everybody at Twitter into a frenzy. And I was reading some of the things that were coming out today from people who work at Twitter actually saying, we have had to spend a week supporting each other based on the news that Elon Musk has now offered $43 billion to buy Twitter and to take it private. And people were saying, well, I may have to rethink my job. No, don't worry about rethinking your job. Elon's already rethinking that for you. So, I find it absolutely comical. He went on to Twitter, about 2 weeks ago and said, what should I do about the lack of freedom of speech? And 90% of the people responded with, buy Twitter. What does he do? He goes out and buys Twitter.
I mean, if he's taking suggestions about what he should do, I have some things. I have some work at my house that needs to be done, and
apparently I need an emergency generator. Elon, if you're listening, I need a generator. So
I could use $100 for a tank of gas. I'm just saying.
Jordan, something's wrong with your sound, buddy. We don't hear anything that you're saying, but we're gonna keep talking until we get there. So Eric, why don't you kick us off with the first topic of the day, which is the mask mandates, man, and what's going on with this?
Yeah, so I mean, there was all this talk just even a week ago, I believe there was an article, Fierce Healthcare, one of them had it out that HHS was leaning towards letting the public health emergency expire. And so with the public health emergency expiring, that would get rid of the mask mandate and things like the waivers and all of that. And as you can see in a lot of states aren't even saying that there's a public health emergency anymore. Even in the, some of the more liberal states, like New Jersey, where I come from, there's, the mask mandate is basically gone.
Yeah.
New York City, I was just up in New York last week, and the mask mandate is basically gone there. And not only is the mask mandate gone in New York City, but you're no longer have to show proof of vaccination anywhere. And, we were up in New York last week. We went to the theater one night. We had to wear a mask at the theater, and we had to show proof of vaccination at a Broadway show. The next night, we went to the Garden to go see Billy Joel, and no mask mandate anymore in the Garden, no proof of vaccination at the Garden anymore. And the mask mandate and all of that in New York City is going away for the theater soon. But, then lo and behold, we get this notification the other day that they've extended the mask mandate until May 3rd. And not only have they done that, but they've extended the PHE. One of the interesting things that I read was that hospitals and facilities were talking about wanting 60 days notice of the expiration of the PHE so they can wind down some of those operations that involve things like waivers and the like. And what I thought was interesting was there was no notification given up until the last minute. So is the extension of the PHE the result of needing this 60-day wind down? But yet they're keeping the PHE in place for now. So it's another 90 days, I think. But the mask mandate is going in only until May 3rd. I'm trying to understand. I've been trying to find something all day long that explains why the mask mandate is staying in place for 2 more weeks.
So that was purely the CDC, right? The CDC basically controlled the mask mandate. Now, that being said, we just came back. Sean, you did too, Eric, but on the flights, I don't know a flight attendant one that doesn't want to see this thing over. I mean, they are past being done on the airplane with the mask. It's causing so many problems. And I really think our stewardess told us on the flight back, or the flight.
You can't call them stewardess. They're flight attendants.
Flight attendants. I know. God, dog.
Or if you're flying on a European airline, it's an air host or an air hostess.
The air hostee basically said on the intercom, 2 more weeks, guys. This is all we have to do. Well, now she lied to us.
But Jordan, let me ask you though. But so, while we're on that, so yesterday, the president of the lobby group for the airlines came out and said, we're perplexed about this. Why is it that the masks need to still be on planes, but you don't have to wear them in restaurants? You don't have to wear them at sports venues. You don't have to wear them in arenas anymore. And I think, obviously the argument is that, he's equating, obviously, the rails and public transportation fall under federal Department of Transportation mandates. Right. And so, what he's doing is he's trying to make an apples to apples argument over something that's not really apples to apples, because obviously something like Madison Square Garden is not a federally funded place. But I still think it's not really, he's trying to make an apples to apples over something that from a funding perspective is not. But I think the point that he's making is pretty good from a just public health perspective. If I don't have to wear a mask at Madison Square Garden for Billy Joel, where I'm sitting around 30,000 of my friends singing my favorite Billy Joel hits, why is it that on a plane in which the DOD has done a study that has shown that the air inside of an airplane is the highest quality air out there because of the HEPA filters, and every 3-4 minutes it's recycled. Yep. And why is it? And even more, we've all traveled. We were just on a plane. When I'm actively eating or drinking, I don't need to wear the mask, and I'm in closer contact with people there than anybody else. And if you don't think I'm not going to eat a peanut at a time,
wait a minute.
It's 2 hours to eat a bag of peanuts.
When you pull the mask off and you're eating, don't you project more spittle? Don't more particles come out of your mouth? But let me address a couple of things. And Pam, you asked a great question, and we'll get to. I try not to give my opinion too often because, as they say, opinions are like buttholes. Everybody has one. But I think we'll give our opinions on this in a minute. But let
Unless
me
you have a
share with you.
colostomy bag.
Let me. I'm so glad that this is after 5 o'clock, and I think everybody listening is going to be grateful for that as well. Because you know what, we don't have to pull the punches. We can call it the way that it is, and I think that's important as long as we use discipline. All right. So a couple of things that's really important when we start talking about the PHE. And before I get to that, I just want Eric to say theater with a British accent one time. Okay.
Say what? Theater?
Theater.
With a
Isn't
British
that how
accent?
they say it?
I don't know.
Okay.
I'll know this
Well,
summer. I'm going to London this summer.
I'll
So
see you
you know,
there.
I'm going to see. You going to see Kings of Leon at the O2 Center as well? Good. I'll see
No,
you there.
no, but I'm probably going to go see the king. So, CMS, here's what it says. CMS will maintain flexibility for certain requirements, such as making temporary waivers available for nurse aid certifications if there are documented capacity issues in training or testing programs. CMS will retain the ability until the expiration, and it goes on and on and on. It talks a little bit about, control and prevention in nursing homes. But what they're planning to do is CMS is ending specific waivers in two groups. One group of waivers will terminate 30 days from the issuance of the new guidance, and the other group will terminate 60 days from the issuance. And basically, what's happening is CMS is returning to their pre-COVID-19 policies. That's really what's happening.
Right.
Go ahead, Jordan.
No, I mean, I think this is, I'll be honest with you. We all thought that under this and the current administration, we'd see the PHE till the end of the administration. But I think it's time. I mean, other than to what Eric and Sean, what you guys were saying is you better believe when that PHE ends. And that's part of the reason these hospitals and different people want the 60 days. We thought the audits were busy. Let this PHE end and see how fast these audits ramp up even faster to look at where this money's been going.
Yeah, that's such a great point, and we'll get to that. So the question here is, do each of you think the PHE should have been allowed to expire, and why?
Yes, should have
yeah.
expired.
It should have expired, in my opinion. It should have expired when the numbers cratered to their lowest levels, and we achieved that herd immunity, and we had control of the pandemic. I think the other reason why it was important to end is again, and I've been trying to follow the science, right? So and I don't want anybody getting mad, but if you do, it's okay. I'm vaccinated, but I also believe in natural immunity as well. And I think it's important, especially in these in these viruses where you have a 99 up to a 99.8% healing rate, right? Recovery rate, not healing, but recovery rate.
Well, didn't CMS say they're not even covering for the vaccination to be given anymore?
They are not covering the vaccination any longer.
Then there's your answer. Yeah.
When did that come out?
A couple weeks ago.
Yeah, like 2 weeks ago.
So CMS, so Medicare. So they're not covering it for Medicare or Medicaid.
Correct.
Yes.
So in my mind, that was I was almost convinced, like Sean, like you, is when I saw that 2 weeks ago, I'm like, there's your sign. PHE's over. And then boom, it's not.
Yeah. Again, I have some other thoughts as to why the PHE is continuing, but I'm not going to get into those.
So Jordan, but my question is from a facility perspective, what is that 60-day ramp down, if that's the right term? What is the 60 days? What does that give them? Yeah, the wind down. What it ramp up and wind down? Why do they need? Why would a hospital need 60 days at the expiration of a PHE? Meaning, what did the PHE do for a hospital that the wind down has now that they need that 60-day time period?
Absolutely nothing. Absolutely. And I'm firmly convinced if you just hard stopped it, and that's what should happen. I mean, it's not like you're going to find where to bury the bodies, cook the books, and whatever you got to do. The damage is done. The paper trail's there. If you've taken stuff that you shouldn't have or used it inappropriately, it's going to show in the audits, and that's it.
I mean, the question that I've always had is when we talk about the 1135 waivers, if you're not licensed in the state where that service is going to be rendered, so even if you get a waiver from CMS on being able to bill, if you're not licensed in that other state, how did the 1135 waiver actually help? Because isn't the point of the 1135 waiver, at least in some regard, that it allows you to be able to bill across and you get a waiver on having to be a participating provider? But if I'm in New York and I'm not licensed in California and I render a service on a Medicare beneficiary in California, I may be able to render that service from the 1135 waiver perspective, but aren't I practicing medicine without a license in the state of California?
Yep. So listen to this. This was just released yesterday. Okay. So yes, and there's our friend right there. Yes. They do need an out plan. Okay. But this was just released yesterday under the public health emergency extended. So they are extending it effective April 16th until July 15th. Okay.
You know what happens July 15th, by the way, right? So around July, that's the proposed rule.
Proposed rules.
Bingo.
So but listen to this. Here's what they're saying. The renewal determination takes effect on April 16, 2022 and runs through July 15, 2022. Listen to this part. Okay. You guys ready for this? While there are indications from the Biden administration that they expect the PHE to continue well into, if not through, all of 2022. Legally, Secretary Becerra can only extend it for 90 days at a time. So again, the Biden administration is actually signaling there is a possibility that this thing is going to go much further beyond July, potentially into the fall, and then potentially into the end of 2022. Folks, I got to tell you, this is a huge problem. And here's the other problem that I see with this. What about all of the states? How does this apply, right? Because in here it says, this action means all HHS CMS waivers and flexibilities currently in place will continue until July 15th, unless earlier terminated by Secretary Becerra. But here's my question to you guys, or to our listeners. What about all of the states that have already ended the public health emergency? I mean, don't they supersede?
We've always gone with
Right.
it. The state rule, the most local rule supersedes, right? And so to your point, I mean, this leaves a gray area that's going to be extremely problematic.
Right, but that's really the discussion. If a particular state has withdrawn the PHE or let it expire, but the federal government still has one in place, what is the effect of that?
Nothing.
Right, other than a mask mandate on trains
and
planes, airports, things of that sort.
I think for our friend Cairo Medicare, a bag of dum-dums is not just a great snack for flying. We should send it to the House of Representatives and to the Senate. And I also agree with something else that he said too, which is, again, if they extend it, it could potentially factor into the elections. And I think that's a very interesting point. But we'll target that a little bit later. There are some other things that are going on in healthcare that obviously we really want to make sure that we talk about. One of them is, and you know what? I didn't say this in the very beginning when we got started. To each and every single one of y'all that is tuned in, logged on, and hanging out with Eric, Jordan, and myself, I can't tell y'all how much we appreciate you. Our numbers on LinkedIn continue to get bigger as I'm watching it, but on the other 8 streaming platforms, our numbers are really strong. So thank y'all so much. We can't tell you how much this means to the 3 of us that y'all are hanging out with us. We do this because this is what we're passionate about. This is what we love. And we want to make sure that all of you that don't have the time to do this research and to do all the things that, to take a look into all the things that are going on out there, that's what we are here for. We want to be that resource for you. So here's something that's going on. I think this was kind of interesting because we started the discussion, and I think this is important to our listeners, right? So I have a Medicare hearing that's coming up in the next 30 days, and it's tied to biomarkers. Okay, Jordan, right in your wheelhouse. Eric, I know you've done investigations on this stuff where basically it was a UPIC investigation and it then went to the QIC. Both of these individuals, not individuals, but both of these entities made a determination to uphold the denial of these cancer genetic tests, right? These biomarkers, the BRCAs for, the BRCA1, BRCA2 for the breast cancer, the prostate cancer. Okay. And what they're saying is that they're denying it because it was not medically necessary. Well, the lab, and then what they said was the laboratory has the responsibility to go and get all of this documentation from the ordering physician. Well, the laboratory made every reasonable attempt to go to the ordering physicians. And the ordering physicians, Jordan, what did they say?
Take a hike. Good luck. Pound dirt.
Pound dirt. Take a walk. Why? Because they're not going to disclose what? Patient protected health information.
Nope.
Right? So the invest and Eric, I'm going to get to you in a minute because you had a really interesting take on this, which had to do with investigations. But here's my point. Okay, in the Medicare Program Integrity Manual, and I think this is so important. It specifically talks about the contractor's responsibility to go and capture this information themselves. And it's specifically for the compliance geeks that are out there. It's in the Medicare Program Integrity Manual, specifically section 3.2.3.7. And what that section specifically talks to is the fact that contractors have an obligation to send, here's what it says, quote, the contractor shall send an ADR to the ordering provider that shall include sufficient information to identify the claim in question. Folks, these are laboratories that are working off of, Eric, what? An order.
Well, and that's the only thing that they're working order.
That's it.
That's all.
They
have
not
no other documents. They
Yeah.
get a script or a pre-printed requisition. The lab is getting, they're getting the sample and they're getting the order. And more importantly, on that order, there is at the bottom the doctor's signature where they are attesting that this item, that this test is medically necessary. So when you get into the fraud world, in the telefrauds with the genetic testing, that's really your linchpin, is that the doctor is ordering a test that they cannot attest to as being medically necessary. When you get an order from a doctor in which there is the proven relationship, doctor-patient relationship, and that doctor is saying, I am attesting that this order is medically necessary, that's it. The relationship between the doctor and the lab may be tangential at best. And when you're talking about, what you're talking about, Sean, is, the two types of testing in the genetic world that we were talking about before we went on air is PGX and CGX.
That's
now
right.
the one that you see the most widely dealt with in the frauds are the PGX. That's the, how does my body metabolize this drug? And the example I gave right beforehand was, I've been taking a statin for 10 years. My doctor already knows how my body is dealing with the statin. To then give me a PGX test to see how my body deals with statins, you can clearly argue the medical necessity for that is probably negated. I've been on this drug for 10 years. But in the world of CGX, which is your cancer screening, then, and particularly in the instances where there's a doctor-patient relationship, you've got a history of it and you've got all of that, and you've got a doctor signing off, and there's an established relationship with the patient because it is your actual doctor, that's where you're getting into it. I mean, I equate this to the scenario that I've been posting up on LinkedIn about my own getting that calcium screening test, right?
That's
like,
right.
I have no cardiac conditions whatsoever. I have a family history of cardiac conditions. And about 8 or 9 years ago, I had a blip on an EKG that led me to have to go for a nuclear stress test.
Right.
And so I thought, hey, let's go and have this checked out again. It's been 10 years, but I met the requirements to have that test. So here's the same scenario, right? The doctor-patient relationship is there. The doctor signs the order attesting to the fact that there's a medical necessity. The patient's record is going to clearly articulate that there is that medical necessity.
But not to cut you off. Here's what's so interesting about this case, right? Inside the actual medical records, which we were able to get under subpoena, in the patient's medical records, all the UPIC had to do as part of their investigation, or all the QIC had to do as part of their investigation, was request the records from the primary care physician or from the ordering physician. In there, it specifically says patient has a past personal history of cancer. Patient has a unspecified productive cough that began 6 weeks ago. Negative for COVID, negative for other viral infections, for other bacterial infections. Patient presents after 7 weeks of unexplained significant weight loss. I mean, these are key factors that would substantiate the medical necessity for why these are being done. But Eric, you and I had an interesting situation with the OIG about a week ago, right? And we brought up the question as it related to pain injections and the fact that the government came back, the OIG came back and said, we don't care whether or not medical necessity is the issue because we would expect everything being billed to be medically necessary. This is a strict liability situation. Can you explain for folks that are out there who are like, wait, what is going on? The difference between a strict liability versus the medical necessity?
Yeah, this is actually an interesting one. So there's a policy that says we're talking about these like facet type joint injections, and there's an LCD that says no more than 4 in a rolling 12-month period for a patient, no more than 4. And anything more than 4 is going to be deemed medically unnecessary without any indication about whether or not it's in the patient's interest or not in their interest. And so there was a study that was done by OIG, by one of the other components, not Office of Investigations doesn't do studies where I worked. It's either OAS or OE&I. But they literally just did an empirically based study that said this policy is anything more than 4 is considered medically unnecessary. They went and they did a data analysis and identified providers that were outliers for having done more than 4 in the rolling 12-month period. And then immediately OIG, through Office of Counsel to the Inspector General, or OSIG, sent what they call a pre-demand letter to a particular provider who Sean and I are now helping, kind of navigate through this. And the thing that's interesting is there was not a single patient record reviewed, 0. So for what Sean is talking about is this strict liability, meaning the policy says no more than 4. If you've done more than 4, you've violated the policy, and OSIG is looking to collect as a CMPL. They're going to look to collect on that as an overpayment with a damages multiplier. Since it's not a self-disclosure, it's going to be probably double damages. So so we were talking, Sean and I right, we talk, Jordan, Sean and I talk incessantly about these things, but this was one of those where not a single patient record was looked at. And I think, when we're talking about medical necessity, there's 2 pieces of medical necessity. There's clinical medical necessity and there's documentation medical necessity. And I think, where there's that difference is if you go to the doctor and your doctor bills for a high-level E&M, a 99215, and an auditor comes back and says, there's no medical necessity to justify this, it's a 99213. No one is arguing that your visit didn't have a medical necessity, meaning you shouldn't have been at the doctor. No one is arguing that. No one is saying that you didn't have a need to see the doctor. You didn't need to go to the doctor. They're arguing that the level of care that you were billed for didn't equate to what was documented. And that's really different than medical necessity from a clinical perspective. And the example I always like to give is the EKG example. You go to the doctor for a sore throat and the doctor does an EKG and the doctor documents every piece of the EKG, interpretation, report, where the leads went, the time of day, the weather, whatever it may be. It's a well-documented EKG with interpretation and report. No one is saying that the patient didn't get it. But there's a from the documentation perspective, the documentation isn't supporting it. The doctor might have had a clinical rationale for wanting to do it. They just didn't articulate it well. In this case, the strict liability is going to be, hey, you're only allowed to do 4 per the policy. You did 5 more than 4. So you did 5 or more. And we don't care about what the medical necessity is or what your clinical decision making is. We're saying strict liability. And so you get into a point where, it's a little bit of a pickle, right? Because at the end of the day, Office of Counsel to the Inspector General is not going to care about whether or not we can justify the clinical necessity for it, because this policy says what the policy says. More than 4, not medically necessary. That's it. You're muted there, Sean.
People are probably like, God, he sounds so much better when he's muted. So, here's the thing, to the attorneys that are out there listening to the presentation as well, you start to go back and you think about this argument that's being put forth by the OIG on a strict liability where they're following the LCD. And then you have to bring up the Azar v. Allina Health System case, which talks about the fact that if an LCD was not put through a formal rulemaking process with a 60-day comment period, then it becomes a de facto guidance document. So the opportunity to be able to argue, and I think argue these things successfully, because when you have a ruling from the Supreme Court, I think it's pretty hard to get a higher level of precedent in legal terms than something coming out as a ruling from the Supreme Court.
Well, the only way you get around that is you'd have to pass a new law that circumvents the Supreme Court's decision, right, which will then probably go back to the Supreme Court. You have this circuitous thing that goes on, right?
Now, the interesting thing about this, right? The whole Allina case, the one thing that the Supreme Court has yet to do is to define what is a substantive change.
Yep.
We're still waiting on the Supreme Court to actually render, to give us some guidance on that. So,
well, I think that's that they've reserved that, right? I mean, because then once you put that in writing, like it's almost like everybody's asking, what's the threshold that then gets us, and then it's okay or it's not. Somebody define that, right? And purposefully, a lot of healthcare law, there is always the ambiguous gray area, we like to say, and I think it's kept that way in some instances for a reason.
Yeah, I wholeheartly agree. So, all right.
Well, but let's talk about that. When something is in that gray area, then you're giving deference to the provider in that, right? Because it's it's something that benefits. And I just had this today with something where there's 2 codes that are very similar, and the client said, well, these are similar, and we really can't find any guidance that says you can't bill both of them. There's some, like on the Medicare side, it has to do with hearing aids and fittings and things of that sort. And CMS is saying this is not a covered code, so it doesn't really matter. But on some of the other payers, some of the payers are saying they'll pay for both codes. Some are saying they're not. Some don't really have any guidance. And so the question becomes, like, when it's a gray area, you really need to give deference to the provider. The advice that I gave to the client today was, if you're going to use both of those codes, you better make sure that the documentation adequately articulates each one of those codes separately, so that if you get denied and you go to the MAT, you're going to argue the policy was gray and we fully documented what those 2 codes were. And here's how we're differentiating between these 2, even though they're very similar. You have it all the time. I mean, Sean, you do a ton of these ALJs. I mean, more than anybody I know. And this has to come up constantly, like, giving
It
the
does.
benefit of the doubt to the provider.
It does. And so I'm so glad you brought this up. And I mean, I swear, folks, this stuff is not scripted. This is stuff that is literally as we're on air talking about this stuff. So one of the big arguments that I make is the treating physician rule. Okay. And I think for the folks that are on listening to us right now, because Eric used an incredibly important word, deference. Well, keep this in mind. The first section of the Medicare statute is the prohibition, and it specifically says nothing in this title shall be construed to authorize any federal officer or employee to exercise any supervision or control over the practice of medicine or the manner in which the medical services are provided, right? So if that's the prohibition, why are we having these arguments? Why are we having these appeals? But I think if you take it a step further from what I just recited for you, because you're right, I do probably 50 to 60 administrative law judge hearings a year. I think my biggest year I ever had was about 100 in a year, and they're nerve wracking. And you heard about my experience yesterday with the judge, but I'll leave that one alone. But from what I was just reciting for you, one could conclude that the beneficiary's physician should decide what services are medically necessary for the beneficiary, right? Because there's a substantial line of authority that holds the treating physician's opinion is entitled to special weight and is actually binding upon the secretary when it's not contradicted by substantial evidence. And the fact is, some of the courts have actually applied the rationale of the treating physician rule in the Medicare cases that we're talking about and have actually rejected the secretary's assertion that the treating physician rule should not be applied to Medicare determinations. And there's a case, if anybody's interested in it, there's a case, it's Holland v. Sullivan. And in this case, what the court actually concluded was this. Though the considerations bearing on the weight to be accorded a treating physician's opinion are not necessarily identical in the disability and Medicare context, we would expect the secretary to place significant reliance on the informed opinion of a treating physician and either to apply the treating physician rule with its component of some extra weight to be accorded that opinion, even if it's contradicted by substantial evidence, or to supply a reasoned basis in conformity with statute purposes for declining to do so. And that's where we come into this whole conversation, right, Eric and Jordan, about judgment error. And a lot of states have come out and said, if an overpayment is the result of an insurance company changing its judgment after paying the claim, in the fact that they're determining the service was outside the scope of the insured's coverage plan, as an example, providers may not be obligated to reimburse the insurance company. It's sort of like ex post facto in the law, right?
Yeah.
You can't put a penalty into place for a crime that was committed previously where there was no statute or there was no guidance on that.
Well, you see that you see that in the medical necessity. You see that a lot with interventional cardiology. I mean, the one case that was probably out there that's one of the more famous ones is Richard Paulus out of Eastern District of Kentucky. I was brought in as an expert as part of a team of people, and I was there to work for the defense with respect to the loss amounts and repricing, DRG repricing. But that's a great example. Is Dr. Paulus was criminally charged with lack of medical necessity on stents, and as many know who do interventional cardiology related auditing and coding, is it's percentage based of blockage, and in some cases payers are saying it's 75%. In other instances, payers say it's 50%, but it's still a judgment. And the interesting thing about Dr. Paulus's case is he was at a hospital that was in one of the poorest communities in the country, which has one of, if not the highest incidences of cardiovascular disease. So of course he's doing more of these. And of course the patients are sicker. And of course, and those calculations, by the way, of it being one of the poorest it wasn't the defense that brought that up. It wasn't made up numbers. Like, these were empirically identified numbers. But, the crazy thing is that, there were instances where some of the insurance said it had to be 50%. Some of the insurance said it had to be 75%. At the end of the day, you can go and read the issues with Dr. Paul's case, but his case went up to appeal twice. And on appeal, his case was remanded back. And, ultimately, his second time up to appeal after conviction, he got released and the case wound up getting dismissed. But you definitely, this medical necessity issue, a lot of times, it's one thing if a provider is performing an EKG on you when you go for a sore throat, right? That's one thing. Or it's another thing if, from a defensive medicine perspective, that's always going to be when, you go to the cardiologist because your primary care doctor has referred you for a heart murmur. There's one test that needs to be done to confirm a heart murmur, ultrasound. But because there's an LCD that covers 20 different tests with the diagnosis of a heart murmur, if you have an ICD-10 for heart murmur, and It could be EKG, ultrasound, this test, that test, and the other, and you've fully documented the record, a doctor is going to say, hey, defensive medicine. And guess what? I have documented this. And I'm saying that this is medically necessary, where you're getting into this judgment call. And I will tell you, at the OIG, if I presented a case to the U.S. Attorney's Office in which the entire premise of the fraud was medical necessity, you would get a raised eyebrow from a criminal AUSA. Because who wants to have the battle of the experts? You're going to have two experts to do nothing more than absolutely confuse a jury over something like, hey, I went for a sore throat and I got an EKG. That's a different medical necessity argument than two people battling over whether it was 50% or 52% blockage of an artery.
Sure. I agree with you. Jordan, thoughts?
It almost gives me a headache and I need an EKG after that. No, I agree with you. I mean, I think that's some of this stuff. It's splitting gray hairs, but at the end of the day, I will go back. I mean, as many audits as we do, I still see tons of documentation missing. And if you still can't do the basics of documentation.
Well, documentation is the key to everything in justification.
But it's still missing, right? I mean, that's the problem. And we know these. And how many of these cases does it take to realize that we still need the core basics of documentation and it's missing? I don't know.
Well, I'll tell you what the problem is. Providers that have been in practice for 5, 10, 15, 20 years, they've never been audited. They've never had an adverse action. They look at it and they say, I've been in practice for 20 years. I'll roll the dice. I'll take the chances and, we'll see what happens.
That's it. But that's exactly the point. It's when when you talk to a provider and a provider says, this isn't a problem. My question is always, is it not a problem because you've been audited or investigated and someone told you it wasn't a problem? Or is it not a problem because you haven't been audited or investigated, so you think it's not a problem? Or your buddy down the street is telling you to do it and they haven't been audited or investigated?
Well,
because it's the only one that matters is if you've been audited or investigated and passed the audit or won on an appeal.
Yeah. Well, it's only a problem when it becomes a problem, right? So, all right. So, look, we could have this debate for hours on this, but I want to talk about something else because the anti-kickback statutes, we have seen a significant level of interest by the DOJ in prosecuting these cases, or at least getting them to the point where they could get big settlements out of these organizations. And the number of whistleblower cases, the number of legal term TAM cases that are being filed by these relayers are unbelievable. Folks, just because you haven't heard about a whistleblower case doesn't mean that there aren't cases going on. These things remained under seal for years. Even the people being investigated have no clue that there's a pending civil or potentially criminal case that's coming against them. Well, an interesting one um, from not too long ago was Cardinal Health. And Cardinal Health is a massive, I'll use the term very loosely, GPO, right? But they provide pharmacy, Jordan, are they a
Pharmacy,
PBM?
pharmacy, drugs. They have software. They have. I mean,
Yeah.
Cardinal Health is all encompassing. I mean, they have. I won't get into the DME space, but they have supplies. You're correct.
Okay. So they settled what the government calls, and I think this is a fascinating topic that we're going to talk about for anybody who has never been through a settlement agreement with the government for we'll call it bad behavior. Okay. Let me just quickly give you the allegations that were put forth by the relators in this case, because this is a pure anti-kickback statute case. And I think Jordan, Eric, and I have talked about this dozens of times. You don't get a pure anti-kickback statute case unless somebody tells on you.
That's it.
It's usually an add-on to a civil case or a
You got to
criminal
tell on, well, in a criminal case, you got to tell on yourself.
case. Right. Well, sort of like the guy in New York City calling the
Right.
tip line, right? Okay.
You got to tell on yourself.
Yeah, you got to tell on yourself. So here's what transpired. The United States so here's what happened. The relayers first allege, among other things, that Cardinal Health induced physician practices to purchase specialty pharmaceutical products from Cardinal Health rather than from competing pharmaceutical distributors. But here's the fun part. By paying its physician practice customers remuneration in advance. They paid these dollars in advance of the practice making any drug purchases and not yet in connection with a specific purchase order. This is a pure violation of the anti-kickback statutes. This is 42 for anybody who's interested, the compliance geeks out there. This is 42 USC section 1320A 7BB. That's where you find it. So the government contends that Cardinal Health caused to be submitted claims for payment to the Medicare program under Title 18 of the Social Security Act under 42 USC 1395 and 1395-3, which is Medicare and the Medicaid program 1396 through 1396 W5, where physician practices seek reimbursements from Medicare Part B and from state Medicaid programs for specialty pharmaceutical drugs. So
I'd love to know what the drugs are that are in question. Where they keep maybe chemo. Well, they're probably going to be your hit list, right? Your Remicades and your chemos. But I'm curious. I'd be curious to know specifically what the drugs were.
Yeah, I'm sure we could. I don't know if in the settlement agreement they're going to disclose that. But
They won't.
Yeah, I'm sure we could. We can make some assumptions on this. But here's the fact. Here are the facts, right? So according to the settlement agreement, Cardinal paid $13 million. Okay. But that's not exactly what they paid. Eric?
Yeah, so they paid. So, the funny thing about these press releases, the press release on these civil settlements will reflect what the amount of money that was paid as the loss amount is, but doesn't go into the greater detail. But in a lot of these press releases, you will see a link to the settlement agreement. And I really encourage people that when you are reading a press release on a settlement agreement like this, and even on the criminal, is to read the information, the indictment. Those linked documents in the press release are sometimes really great documents to read because you'll get to see a little bit more of that granular level of what's going on. But in a civil settlement, there's usually the amount of money that's paid as damages, but then there's always interest, relators amounts, things like that. The reality is that in the Cardinal Health case, it exceeded $26 million. Now, if you read the press release, you say, oh, 13 million, that pales by comparison to the fraud. But what happens is they pay the $13 million back. They paid about $12 million in accrued interest that went back for almost 2 years. plus attorney fees, plus the relators amounts. The thing that people, I think, don't fully understand is when a civil settlement is done, that money goes to a few different pots. First and foremost is the goal is to make the programs whole. WHOLE, not HOLE, because we know that there's always going to be a hole in the program, but the plan is to make the programs as whole as possible. And we all know that in a settlement agreement, the amount that is settled is never the dollar for dollar amount of fraud that is believed to have actually occurred. It's a negotiated amount. So let's take that argument off the table because we know that that occurs. It's never dollar for dollar. But in the case like this, the $13 million goes back to the program as the, whatever that single damages amount, or if it's a double damages amount, it's $6 million. But the way that it goes is programs get made whole. Medicare gets made whole. Medicaid gets made whole. And then the interesting thing that I think people don't always realize, and I'm not sure if, Sean, you fully got that when I said it, when we were talking about today, is the OIG actually gets reimbursed for its investigative costs. So
no, I understood what you were saying.
No, I know you understood it, but were you shocked by it when I told you that? I know you understood it. You're not, you're smarter than the average bear, but a lot of people don't realize that the OIG gets paid back for its investigative costs.
Yeah, I mean, if you enter into a settlement agreement and you're ultimately admitting but not admitting that you were a bad actor, yeah, you're responsible for the outlay of funds by the federal government to make them whole.
And does the federal government define that, Eric? I mean, do they define that? Is that a formula? Is it a set amount? I mean,
so there is, yeah. So interestingly enough, the OIG. So we were required when I was an OIG agent. Then one of the things that you were always hammered about was your timesheet and your timekeeping. All of your cases, you must track that time. Administrative time was tracked very strictly. Case-related time was very strictly done. It's done for a couple of reasons. One, from a budgeting purpose. When the OIG gets a budget, there's discretionary money and there's mandated money, and a good chunk of the money that comes to the OIG comes out of the Medicare Trust Fund. And so there's a repayment structure and there's a formula. So they would say, hey, you're on an 80-20 this fiscal year. It's 80-20. 80% is your Medicare Medicaid work. 20% is discretionary, meaning grants and what have you. And there was an entire calculation that was done where they would say, all right, the average hourly rate for an agent is this. And so when a case is settled, exactly that, Jordan, we would run a report and you would come up where it would be X number of hours were worked and this is what the costs would be. And you would fill out a form and that would go back over to the U.S. Attorney's Office and DOJ. And that would be part of how they did the calculation on ultimately U.S. Attorney's Office doing the what is known as the HICFAC money, the healthcare fraud money. And yeah, OIG would ultimately get reimbursed for, the OIG would ultimately get reimbursed for the cost of investigation that would come out of any of the money that was recovered back in through the settlement agreement.
Got it. Well, Sean, you covered last bit here. You want to add anything to that one? Oh, Sean muted.
Yep, I'm having that problem today, huh? So, look, I think it's these are all valid points. I want to see if I can do this for whatever reason it's not allowing me to do this overlay of the chat comments. But if you're not able to see some of the comments in the chat, Cairo Medicare, I want to go back to something real quick, if that's okay, Eric. They brought up, and Jordan, they brought up the fact that medical necessity is a legal term defining what a third-party payer will pay for. That does not mean that the care rendered was not clinically indicated and appropriate. I agree 100%. And you're spot on. And my response was, in the Medicare program, medical necessity is defined under Title 18 of the Social Security Act, Section 1862 A1A. And what it says is, notwithstanding any other provision of this title, no payment may be made under Part A or Part B for any expenses incurred for items or services which accept those which are for items or services described in a succeeding paragraph and are not reasonable and necessary for the diagnosis or treatment of the illness or injury or to improve the functioning of a malformed body member. So what I provided for you in that above statement right there, that is the legal doctrine by which evidence-based clinical standards are used to determine whether a treatment or procedure is reasonable, necessary, and appropriate. And those are the three things that I go back to. Every coder, auditor, compliance officer should ask this question of their provider when they're trying to make a determination on appealing a claim, or even if we're, prior to submitting a claim. Was the service medically reasonable? Was it medically appropriate? And was it medically necessary? Those are the three things that should be asked. Right. And again, we went in a completely different direction than what I thought we were going to go today, because we talked about the treating physician rule. We talked about medical necessity. We talked about the legal doctrine for medical necessity. I love the interaction that we've had with, all the folks that have been on here today. I think this has been great. I know the only other thing that I was interested. Go ahead, Jordan, please.
No, I was going to say, I mean, the only thing, and I'll touch on it quickly, was the fact sheet release, right? So basically, guys, if you weren't aware, on April 11th, the Biden administration announced new actions, basically to lessen the burden of medical debt. And this is very interesting that they step in and they kind of take the role in this and the lead. But basically what they've said is they want to hold medical providers and debt collectors accountable. If you're not aware, a lot of people, hospitals got a really bad rap. Even during COVID, they were going after collections with patients that weren't paying. They also want to help lower income Americans and veterans, get debt forgiveness. Part of this is obviously with Experian and credit scores and that kind of stuff. You're not familiar with the credit scores, medical debt will obliterate you. And that's what their study showed, is that it can't and won't be part of the credit. Where I thought it was interesting that HHS and where they're going to let this go was Secretary Becerra said and made very clear that he wants to take information in a data request from 2,000 providers on their medical bill collection practices, lawsuits against the patients, financial assistance, financial product offerings, third-party contracting. They want to take that. That's correct. That's why they were there, Eric. I love that, man. Absolutely. But they want to take that and look at it, and they're going to analyze that. And what they're going to find is what we already know. Medical debt, it's a serious issue. It's not one that should be taken lightly. And I think people avoid care. I truly believe this. People avoid care for the sheer fear of cost and what it would do to their family, and all that. I mean, I just think that's the case. And that's sad if it truly is the case. And that's what they're going to find.
So 2 shout outs. Eric, you want to give the first shout out?
Yeah, you get
just brought it up.
Yeah. So, part of this whole medical debt forgiveness piece, I should say, as it relates to your credit score is, the three of us are very, very intrinsically connected to an amazing charity called $4. We're all connected some way, whether it be on the board or just as a strong supporter, and help to shape the way that works. And the one thing about $4 that's amazing is they don't buy the debt and then negotiate a discount on that debt like some other charities do. What $4 does is it works with the patient to get the charity care that they're otherwise entitled to. Like, there's no magic to what they're doing. They're just helping people navigate through a process that is otherwise unbelievably burdensome. And, as part of this announcement, the founder and the head of $4, Jared Walker, who's an amazing guy, he was at the White House the other day during part of this, with the VP. And, this is totally apolitical. Like, this is just people have crippling debt for things that they just don't know about. I mean, we talk about this all the time, but where in the healthcare world, other than the healthcare world, do you not know what something is going to cost you before you actually get it? In no other consumerism can I think of a thing where that's the case. And so this is an important piece where an organization like $4 can really help people, because people now don't need to worry about, am I going to be able to afford to buy a home for myself because I have this crippling debt that's not my own doing or my own fault because I was underinsured or uninsured or whatever it may be. So this can be a great thing for people where, the debt doesn't go away, but you shouldn't have to suffer for the rest of your life over something that's just, potentially crippling otherwise.
And Sean takes this personal, and I do too, and Eric, you do too, but a huge supporter of veterans. And they made that clear that since the pandemic, the VA has canceled or refunded $1 billion in co-payments to over 1.5 million veterans. That's the right thing to do and should have been done. And did it take the pandemic to do that? Anyway, if that's the pathway that they're going, that's just smart. That's not political, right? That just is smart.
No, I agree. And Mark Maloney, it's really it's kind of head scratching for me on why Governor Youngkin vetoed the bipartisan bill on canceling medical debt. I don't really understand that one. It doesn't make a whole lot of sense to me. I've actually tried to read the nonpartisan explanations on this, and they make as little sense as the partisan explanations for why he vetoed those. But if we could figure something out, maybe I'll reach out to Youngkin's office and ask for a statement on this and see if we can't get something. But the last thing that I want to, as a shout out that I want to do, is to my friend Clint Pulver. If y'all don't know Clint Pulver, he is absolutely unbelievable. Show the book. Do you have the book? Oh, the drummer. There you go. You got the sticks. Clint Pulver is an Emmy Award winning musician. He is part of the undercover generation that goes into organizations to uncover why people don't like working there. He wrote a book called I Love It Here. I've had him on my own personal podcast. He's an unbelievable friend to me. And he just announced yesterday that he is now on his 6th printing globally of his book, I Love It Here. If you've not read the book, it is not like like a Stephen Covey book, who I love Stephen Covey, but it is so far beyond that. And he tells the story about Mr. Jensen, who inspired him to become a drummer. And one of the funniest lines that he talks about is as he's moving his hands, Mr. Jensen, his elementary school teacher, says to him, "You're ambidextrous." And he says, "No, I'm not. I'm Protestant." and or something like that. And it was actually, from a young kid's perspective, it was actually really kind of a funny, cute story that he told. But I just want to give a shout out to Clint Pulver, who is just an incredible human being and such a talented musician. Was a drummer for Tim McGraw, for Kelly Clarkson. Yes, the author is Clint, Clint Pulver, Pulver. You could get his book on Amazon. You could find him on LinkedIn. He is absolutely one of the most down to earth, one of the most humble people, and probably one of the most exciting speakers you'll ever get a chance to hear if you're lucky enough to have him as a keynote speaker at a conference that you go to. So with that said, Eric, Jordan, I want to turn it over to you guys for any last comments, any last words before we let these good folks go and enjoy their evening.
No, I think the 3 minutes we were over make up for the 3 minutes of the power outage at the beginning. I think we're good. No, I enjoyed this one. I think, hold on. There's going to be a lot of changes between now and the proposed rule, as you've heard today, and we're just going to keep covering them as we hear them.
Yeah, absolutely. I mean, it's amazing to me how each week we have an agenda. I don't think we ever get through our agenda, and we always get a couple of twists and turns, and it still appears that the train is going to go off the rails, but yet we always seem to slow it down and make it all happen. So it always works out great. I'm always appreciative of it.
Absolutely. And to all of our men and women in service, to all of our veterans, thank you for your service. Thank you for all that you've sacrificed along with your families. We love you. We appreciate you. To each and every single one of you who's continued to tune in to the Chuckleheads, we will be back again live next week. We will be announcing the day and time and a new set agenda. I actually have a few hearings that are scheduled between now and our next live show. So I'm sure I'll have some more interesting conversations. Eric, you and I have a lot going on. Jordan, you and I have a lot that we're working on in data for our clients. So again, on behalf of Eric Rubenstein and Jordan Johnson and myself, Sean Weiss, we want to say thank you for tuning in, logging on, and hanging out with the Chuckleheads. Thank you, thank you, thank you for making this a #1 rated show. Y'all take care. We'll see you next week.